Correct that this group is suggesting that the provincial health services are not going to access men, and therefore adequately, and therefore if we're going to want to get to the 90s and we want to access men, it's going to have to return to a model of direct service delivery by us as implementers in order to set up spatially more relevant clinics in terms of spatial representativity and time, so it's outside of the work hours, etc. I mean, have we got to that level of clarity around this? Because I'm unsure about that.
From my perspective for FPD, yes, that's what we're going to do.
So that's going to be a recommendation.
Yep, it's going to come out here. I think it's a necessary. And I mean, the ideal would be is if you can negotiate it within the public sector environment, etc., rather than go back and build a clinic somewhere, etc. But I think if we want to hit that target, it's got to be done.
But that requires a very separate strategy when it comes to funding streams, because either the donor agencies are going to have to return to an overt policy of funding direct service delivery, or it has to come out of national, provincial coffers to agencies that can provide this.
So, Tim, addressing this thing about how information flows to partners, we are, as USID partners, are absolutely convinced that that the switch of the funding is away from health system strengthening and it is back predominantly to direct service delivery. So we switch, we're appointing staff, we're busy appointing counsellors to put them back into clinics. It's all of that, that's basically where the emphasis is. And the interesting thing, which I mentioned earlier in the discussion with Treasury, is that if we do this, if we document it, if we show it's working, and if we can quantify what it costs, there is a possibility that funding will, as the PEPFAR money runs out, that this is not we're doing something for 2 years and all the services closed down, that there will be a matching of that money, but we as the partners need to be very careful in how do we advise. Is this something that should carry on in the future? So at the moment, I don't think we should be doing nice to have stuff. We should be doing need to have stuff. And then the other thing is that they want to know is who should be doing it. Do we think this is something that can be done by government, the district, or is it something that should be outsourced in the future? Right, we have 12 minutes left before lunch.
Yes.
So for the next 12 minutes, you've got the microphone.
I was hoping I could shift the conversation a little bit away from men. And I thought it was interesting that Francois put migrants as a key population into his presentation. It really feels like there's a lot of stories that are emerging, anecdotal stuff, that really speaks to the fact that migrants are being treated really badly within our healthcare system. And so I guess, again, I know it's a question, my question would be, do we just leave that kind of stuff to the advocacy groups, to the Section 27s, to those guys? Or is there something operationally that we could do to make clinics more migrant-friendly in a way that we get away from this kind of xenophobia that's going on?
Right, who's volunteering to speak to this subject? Francois.
Both HIV treatment and TB treatment are public health interventions now. Okay, TB treatment's always been a public health intervention. The test to treat thing that we're looking at is now a public health intervention. Excluding huge chunks of your population because for whatever reason doesn't make sense. So I do think that we need to be, if we're going to get to 90, we need to say to people, you need to get to 90 for everybody, not just 90 for South Africans, because it's been known that South Africans occasionally will have sex with non-South Africans. So you do need to kind of get that through your head. I know it's an outrage. Your Afrikaner heritage is wait, Afrikaner heritage.
Many years ago, we were doing brainstorming in a class, and we were talking about prevention, and somebody came with this idea that, well, maybe you should, this is terribly politically incorrect, but they said maybe you should have people tattoo their status on their head. And somebody else said, no, you should tattoo it here. And then somebody said, by the time you get to that point where you read the tattoo, it's too late to turn back. So I would guess by the time you see the national flag tattooed on somebody else, it's probably too late. I think Francois has raised a very important thing in quite a few of his sessions now, is that if it's 90, it should be 90 for everything. We should be aiming for 90 amongst men, 90 amongst unemployed, 90 amongst people employed, 90 amongst foreigners, 90 amongst government employees. And I think that's it's a very simple way of putting it, but it's a paradigm shift. And it would be interesting if one could start getting some data on that you could say, you know what, do we have 90% of private employees tested? Do we have 90% of public sector patients, employees tested? I think it would be very interesting. So I think we're pushing for that. Again, I've got no idea, and I don't think that there's been any. Has anybody been doing work amongst this group that's been looking at migrants specific? Because that's normally where MSF plays around a bit, and the IOM. It hasn't really been a big focus amongst PEPFAR. So it's something that all that we can do is we can do a recommendation for you to go out there and think about this. What can you do at the facilities you support, the districts you're working in, to help migrants access services? We are not seen as a terribly friendly country in terms of migrants. Right, we have 7 minutes left. Is there anybody who wants to, before we break for lunch, are you all happy that we've covered all the subjects that was raised through Professor Venter's talk? Have you found it productive? For God's sake, say yes. Yes, it was great. We've come up with some new ideas. Right, so we will put all of that into documentation, get it back to you, and then I suggest that we take a break now, and we're going to break for lunch.
So thanks very much for giving me the opportunity to be here. It's just funny that you were talking about colors and seeing. I've got one contact lens that's not right, and so I've had to put my glasses on, so if I don't see anything, you'll understand why. If you could just... Do I have to start this? While we're waiting, just to say that the opinions in this presentation are not representative of the National Department of Health or the National Health Laboratory Service, but are opinions that I've put together with data I have received. So I'm hoping... Okay, now you know why Floyd is in charge of special projects for me. So I'm talking on behalf of a whole group which have consolidated to deal with HIV and TB in laboratories, as well as liaison with the Department of Health. And we called the National Priority Program, and actually set up in 2010, and I can't believe that so much. It was a 6-month project which has turned into a 5-year one. I've been asked to talk about the last 90, and I always say what's in a number when we talk about viral load. Floyd, you may have to... Okay, so I don't think the colors look completely right, but we're talking about, by 2020, having 90% of all people receiving antiretroviral therapy having durable viral suppression. And you'll see from my data that this is not impossible. However, just to put a reality check on what it's going to take globally to put viral load access available to everybody is an extraordinary number of tests. And if we have a look at even 2015 and 2016, South Africa probably accounts for about 10% of the expected viral load numbers. And fiscal year to date, we're already on 3.1 million, and I think we'll reach the 3.5 million target by the end of our fiscal year. This is really, okay. So the messages really are that context is important in how you plan to use your viral load. There's really a diminished importance of CD4. And when I wrote an editorial about 2 or 3 years ago now on reducing CD4, I was put on a plane to Geneva to explain myself. But I think we can say from studies presented today that that's the case. However, the message might be that have a look at all the laboratory tests again that we do, and maybe we should be rationalizing some of them to pay for what is going to be an extraordinary viral load volume. So I'll show you how we're doing with viral load suppression, and then I'll describe options that we've been looking at for access, ensuring greater accountability, and I'm sure these are all the correct words taken out of the 1990 document. Quality, and for us, quality can mean various things. It can mean all stages of the laboratory life cycle, pre-analytic to post-analytic. And then I think access for us, when we start talking about having 7 million viral loads to be done in 2019, 2020, you know, that's almost a quarter of the world's viral loads, and they're just a handful of us doing them. We like our work to be done on science-based implementation, and I think you'll understand it's never been sexy science, but it is now. We do have disaggregated data, and we have some ideas of how to devolve work to the community with community-centered, and rather than using the word incentivized, we call it compensated task shifting. So this was just, I'm sure you've all seen South Africa's investment case. The bottom line for me is forecasting for viral loads, which was pretty simple up until last year. As the acceleration goes, we're not yet able to predict the rate at which this will happen, and this makes forecasting exceptionally different from a laboratory perspective. For the viral load, we've always tried to standardize the program dramatically, but we may now have to expand the footprint, and this will include point of care and laboratory-based testing. So what are we worried about? We currently conduct about 3.94 million CD4 tests annually, and that has stayed stable the last 2 years. We did 2.9 million viral loads approximately last year and about 360,000 EID assays. So when I say in this fiscal year we're heading for 3.5, that's quite a substantial jump. So we've jumped by 30% of what we had actually forecasted or expected. And then I don't think we should forget that HIV and TB go together, and we do have a very extended network of gene expert assays. What I do want to say is for the NHLS or the laboratory services, just these few tests account for 30 to 40% of our expenditure, as opposed to what you would put us in as 10 to 15% of the total budget. And if we're aiming for universal testing for HIV and screening for TB, well, I don't know, we've got some serious planning to do. So we know it's the most effective measure of treatment success. I just want to point out, I don't know where Francois get his 1,500 from, but when you start looking at viral loads, be careful who's asking you. There's just been a huge big debacle about matching data from different countries because viral load suppression is called different things in different places. It's a strong biological marker for adherence, and we can now link percentage virological failure or absolute numbers right down to facility level. And this is really to target our interventions. We know, or you know this better than I do, that 2 annual appointments correlate well with the CD4 greater than 500 and virological suppression, and that things like poor socioeconomic status and all the things you've been talking about today are the reasons why we don't get the viral load down. Having said that, the less than 400 only accounts for about 4% of the tests we get into the laboratory. So I don't know what the big fuss is about the number 400. By the time you're non-adherent or have some drug resistance, you're in the tens of thousands. And you need to think in terms of logs. So what do we know? Most will reach virological suppression, but your greatest risk is in the first 3 years. you know more about adherence and patients than I do, but you also know that if you can get your viral load down to below detectable levels or below 1,000 or however you define virological suppression, transmission, mother to child, between partners, community viral load, which we can now also quantitate, goes down dramatically. So I wanted to put this here because I think it's one of the Department of Health's very well written documents on adherence and compliance. And there you can see it puts viral load at the top of the list. And I bet you can collect 500 parameters for me. The only one that will stand the test of time will be the biological marker, the viral load. This was just to show you that we're increasing continually, but also our suppression, and I'll get into more detail, has also improved a bit over the years. Okay, so how far are we off the mark? If we have a look at what we think of the cumulative number of ART patients in 2014, we had 2.6 and 2.95, and when I use these numbers, these are not Department of Health numbers. They're numbers that we've achieved by doing probabilistic matching on the NHLS database. So although it's correlated to DHIS data, and we've put the two together, and I can't even explain it, Sergio's not here, they're pretty close. What we can say is that we're still not giving everybody greater than one viral load assay. But the proportion of all tests coming into the laboratory that are virologically suppressed is about 78%. Now, does it vary? I mean, there's some which are 87. Don't get excited because that's the national average. There are some facilities that go right down to 47%. And so if we were just to list these, we could do targeted interventions at the problem sites. But this is going to be an extraordinary effort to get that last 20% right. We're supposed to, as it's my preference, but what it's supposed to show you is in all our maps, in all our presentations now, we've got green, amber, and red. And your degree of red means you're in trouble. Your degree of amber, you better watch out. And if you green, it's go. And we can do these kinds of maps for HIV, for TB, basically pretty much. And you can see the percentages of people in care and on ART with viral loads less than 1,000 copies. But what you maybe didn't see there, and I will maybe show you a few more slides, is at the top, depending on the security level we give, there are summary indicators, CD4 viral loads, cryptococcal, everything that can be looked at. It can be done at a provincial level, but if you click the drop-down, it can be done at district, sub-district, or facility level for monitoring. So this would be the global view that, say, Dr. Pillay and Dr. Panini would want to see, but you can break it down all the way down to facility level. So I'm not going to go on about when to start, I think, and why we thought that CD4s were not going to be, why we didn't invest in 100 million CD4 point-of-care analyzers was because we knew what was coming, and that was probably eventually test and treat. One thing that no one mentioned today, which I just want to tell you, this is just the people failing the first-line regimen and their drug resistance. What it does tell us at the end of the day with those are all the drugs, and again I've got red, green, and yellow, which you can't see. What it does tell us is our second-line regimen is probably still okay. The scary one, which I haven't put up here, is, and it has to be presented to Dr. Pillay first, but transmitted drug resistance is reaching moderate levels now in South Africa, and we are no longer below 5%. Okay, so I'll go through this quickly, but every time you just make a quick change in the guideline, it means I work for another 10 years on something. But guidelines and the acceleration have had major impacts on our volumes, our choices of equipment, are going to carry on making differences to our operational plan. And what I'm trying to say is that a strong R&D base is required continually to support this change. And with this, we're addressing access, quality, and science-based plans. Okay, so I'm going to talk there, all the clinical drivers. This is what you debate all day, and then you give me the one line that says, okay, by 2017, I need 400 viral loads. Not a small task. I could outsource it to the whole of the US and they wouldn't be able to do it. Technology drivers. There's new technology, highly automated technology available now. Point of care assays, more sensitive assays. There's place for continuous quality monitoring. So that laptop that I've got over there, if I wanted to see what Kimberly were doing with their TB work or with their viral load analyzer, I can sit and do it here and I can send a message, hey, what's going on? All right, so it was a highly centralized model which will obviously need expansion. It's amazing though, and some of the dots aren't there, workflow efficiencies allowed us to use the same footprint for viral load, which was highly centralized, to increase testing volumes by about another 1 million. So most still come in as whole blood plasma, and we've done a lot of work on dried blood spots. But now what we're going to have to do, and these are where the plans are working on, those are all your clinics that have been GIS mapped. The viral loads have been mapped, the expert labs, the CD4 labs, and to get to the 6 to 8 anticipated million by 2020, we're going to have to use a much expanded footprint. This is an outdated slide. What did I want to show you here? I can't remember. But if you have a look here, what is very, very useful, but again, this is just total numbers of viral loads, suppression rates from the previous year, 76.97. I don't know if it's significant to go up to 78.7 as the national average. And we do the same for the DNA PCR. So we have to make some critical choices with viral loads, and I'm not going to bore you with this. We have to go ultra high throughput no matter what anyone says with those numbers. Can we use DBSs? I think yes, based on our data. Can we use multifunctional platforms? Yes. Can clinics use POC? Yes. But there's a lot of work to be done on workflow adherence, and our randomized control trial did not show good results. So there are a lot of decisions we have to make, and we don't do this on our own. We have a core technical group that consists of engineers, costing, biostats, implementers, clinicians, and laboratory people. Doing it again. Okay. And so this is not a small amount of R&D. And so when you just want to dismiss implementation science as not important work, remember what has to go in behind the scenes to develop what you see as the end result. Okay, next slide. Oh, you'll have to just press it quickly. So this is just showing you, and these have been a headache to get up and going. We're the first in the world to put them in. But these are huge analyzers that you just throw the trays in, you put the reagents in, and they can do 1,400 tests in an 11-hour period with one relatively skilled staff member. Next slide. And these are obviously, you all have been talking about point of care. If you want to know today, can I go and buy a point of care viral load for you? No, not in the quantities you need, and the ones that are coming are only likely to be available in 2016. And a whole stack of those are going to fall off the map. Next slide. So we've done all the validations that we can, for point of care. And I won't bore you with the data. Is this going to work? Okay, so new insights gained from all these validations and work, that the highly automated analyzers from companies like Roche and Abbott and Cepheid work in country. We can use them with whole blood as well as dried blood spots. What we did see is that laboratory validations of one instrument against another, and this is work Francois did while he's doing his emails, which say that actually if you really want to see how viral load works, you need to do it in serial cohorts, and I'll show you. We might need to do different ways of doing stats once point of care platforms are in place. And just the whole reason of the fuss about dried blood spots, and I mean, I think you get to a point where there's only about so much you can get out of a dried blood spot. And at the lower levels, the problem is you still have, all of these are total nucleic acid extractions, so you still have DNA. And it really is incredibly difficult to get rid of it. We have, however, been able to show that certain instruments work better for certain situations. The Roche is more sensitive, so works better for infant diagnosis. The Abbott, which might be less sensitive, but might work better for dried blood spots in the undetectable range. So a lot goes into just delivering that result, okay? Next, oh, it's me. And then the last thing, which is I think the only thing you're really interested in today, so I'll spend a bit of time. Result access, and this is your area of expertise, Tim. If I show you some of the pictures of the SMS printers with rolls and rolls and rolls of paper out, we'll talk about SMS printers. We'll also talk about how ESCOM has absolutely crippled many of these programs with difficulties in signal, blowing fuses, despite having UPSs. It's unbelievable the effect of power on laboratory services. I'm not going to talk more about the clinic-lab interface. Tim is the expert. But I am going to talk about some of the dashboards we've got and some of the projects we're looking at for linkage to care and to support adherence. And we even inside our organization get confused with what we're talking about with dashboards. There are dashboards on instruments that give you performance monitoring of the analyzer. There are dashboards that arise from our central data warehouse that can give you the kinds of slides I showed before. And then we have a new project which is called an mHealth Hub, and many of you would have been involved in it. We have everyone from Vodacom, captains of industry, the NHLS, the NDOH representation, into a hub which we would like to be able to meet all the requirements of people outside of this room. Remember, all the results go from the laboratory analyzer into a laboratory information system, which then goes into the central data warehouse. That has to be maintained in a very stable fashion for patient results. So to meet all these needs of apps and all sorts of other things, we've created what we think will work as an mHealth Hub. And I'll be talking a little bit about that. And then lastly, we're working with a company called M4Jam, who said to me today they're absolutely tired of working for nothing. And we have to prove one of these projects work very well. And this is the mobile money banking scenario, which is able to compensate for task shifting. So this will be addressing some of the 90-90-90 buzzwords, disaggregated data. I think most importantly, accountability, linkage, community-based task shifting. The clinical laboratory interface, you know better than me what goes wrong there. What I can say is that we've developed a system of different middleware softwares that can connect our point of care analyzers to a central data warehouse. So while costly, it's feasible to keep all the data in one database. But more and more, we are using remote connectivity or cloud-based options. So I want to explain the SMS printer. It's a great design, and it now has a bi-directional where someone can query. However, its better aspects of its design have increased the complexity and the requirements for signal. And in a time period where signal is so poor in many sites, and Floyd will kill me if I say this, we've had to put antennas on them, or we may have to revert to the simpler model. And again, a lot of it is batteries running flat, not being put on, no paper, but we can tell that from a distance. We can tell what the problem is. It's also mapped like that. Dark clinic, printer status, printer okay, battery signal strength 74%, scanner connected. We can talk about models for point of care implementation, but I think I'll leave that for questions. And this is a very complicated slide, but we feel there's no such thing as the ability in our context to do total decentralization or total centralization. That we're going to have to fit many of these tiers, many of these different types of laboratory structures, and we already have many of them in place, except maybe the community laboratory tier 3, to be able to handle the sheer volumes. And there's a very nice paper written on that. I put this in. This is the new CEO of the NHLS, Ms. Mochale. And I can tell you these mobiles, as has been discussed to date, have been used by many people across the world from a design perspective. It has its own generator, water, can do the testing on site, but it's really expensive. The yield is often very low. And I'm not sure how many of these we'll be able to maintain. And here comes the things that we really are focusing on. So data centralization has been work we've been doing for 10 years. We now have big data. Every single laboratory test requested in the public sector, whether it be a viral load, CD4 or creatinine, goes into the same database. And even if it's a manual test done in the NHLS, it gets entered into the laboratory information system. So we're talking about big data. Until a short while ago, we couldn't afford the servers to run this kind of data because we were talking about how many millions of data points, Floyd? Millions and millions and millions. We now have the servers that can produce results pretty quickly. But what our needs are here is that sustainability. Once we've trained people up to be able to manage this data warehouse, we lose skilled staff very quickly and the maintenance costs are high. So anyone who'd like to invest in it, right to care, have done so far, I'll take your money gladly. The data dashboard, what we found is that this can give you real-time accountability. It's about to be released pending the Department of Health's security levels that are going to be defined. But theoretically, all of you could get your results down to facility level. If you didn't want them at facility, you could get it as aggregated data. It's been so far done on probabilistic matching, and we have done it against gold standards at various sites having Therapy Edge or alternative clinic platforms, and it actually works extremely well. What our needs are, again, is to maintain high-level skilled staff, because this kind of matching, going retrospectively and possibly for a period going forward, requires significant skill. And a unique identifier is critical. So maybe the minister will have the global picture, the provincial heads will have a provincial picture. You could go down to every last cadre of the staff, and if you wanted to, it could even go to the patient. So we've put, so it really is extremely powerful. I can't demonstrate it live. I'll show you some pictures because I don't know what the speed is here. But the next thing is what we call the mHealth Hub. We've just had a huge forum for the NHLS, and we've got a whole lot of public-private partnerships with Space for More to be able to, in future, we get a request a day to push data into an app. What we do need for the POPI compliance, for security compliance, is to not bog down our central data warehouse staff with pulling out individual bits of data for everybody. We'll show you the structure, and Lindsay at the back can describe it to you. It's currently running in 2 randomized controlled trials, as well as 4 pilots for MDR. We can really push our data to any platform, and this can come straight off the laboratory system, or it can go via the data warehouse. And so those are, if I have to say, these are the things that we currently think are our biggest assets for you, besides delivering viral loads. But I was also asked to put things here about what we need from partners. Well, I think I did. We need assistance. There are only about 10 of us who can train. The lady who does the dried blood spots, there are only 2 of them, and she has to train all regional, provincial training centres. And what's happening now with the birth PCR, don't underestimate the drama, because the sisters who work at night cannot come for training in the morning. So we're now having to do night training in labour wards. It's not sustainable for us, and this is why we're requesting collaboration. We have it at the moment with Right to Care, but we absolutely need everybody's legs on the ground. And it could be just simple things. How do you collect a viral load? How do you interpret it? What do you do with the patient? Not rocket science, but if you go out into the clinics, no one will know with a RIF-resistant, well, not no one, but only about 50% of people are following the gene expert algorithm for a patient with RIF resistance. And I can tell that because I can see what comes in afterwards for the patients. So, summary indicators, and these are not up to date, and I might get murdered if I explain it incorrectly. But if you wanted a high-level view, I mean, we've changed that. You can change it to 350, 500, whatever you select at the top. So you can then work out the number of people who had a CD4. So you can work out the percentage of people in care and on ART, and this includes people on treatment from the DHIS, but the number of people with a viral load done in the last 12 months is the number at the bottom. So you can see there is a gap because not everybody's getting a viral load. But having said that, the percentage of people that we can demonstrate are in care and on heart who have a viral load done at least annually is a fairly high, it's about 89%, which I couldn't believe when we pulled out the data. So this is just how it can be presented provincially for everybody. And you can see even provincially the differences across the provinces. But when you do it by district or sub-district, these look horrible, a lot worse. So we can provide national trends, provincial trends, and then patient care. And here my nice red, yellow and green maps gone haywire. But this is the one with the viral loads. What it does tell us is we've still got quite a few reds to deal with. The interesting thing with the TB map, if you overlay susceptible TB versus drug resistance TB, the maps are completely different. Cape will have high rates, a high prevalence of susceptible TB, low resistance. Limpopo, lower numbers, lower percentage of TB, but very high resistance. So on the heat maps, you can just get an idea looking at it. And that's, I don't know if I should let Lindsay or maybe Lindsay you can pick up. We can already do this. If we get a RIF resistance result, and these are some of the projects we've been doing with Johns Hopkins and a number of stakeholders, you can immediately send it to the SMS printer. It can be hard-coded to a patient phone. You can send it to the provincial district coordinator, the MDR-TB initiation site, and then you can report to stakeholders. This costs an enormous amount in SMSs, so we are working with people like WeChat and who are going to provide it for nothing, hopefully. I'm going to, and you wanted to, this was a slide I just added because you wanted to know about the unique identifier. Floyd just pulled out the first two, and he pulled out Chris Hani Baragwanath Hospital, but the trends are the same everywhere. You can see that most people will fill in age, gender, and hospital ID, and doctor's name because they've been pushed into doing it. And then no one puts in the ID. And this is a trend right to varying degrees across the entire healthcare system.
And this is a province that approves ID numbers.
Yes. I mean, some do better, Floyd. Floyd can, if you wanted to see how Gauteng was doing, he can show you every facility. This was a presentation Lindsay did at Captains of Industry and all over for the mHealth Hub. Do you want to do it, or do you want to let me massacre your presentation? So, yeah, you can. So Lindsay has been doing a great job in coordinating all the mHealth activities for the NHLS, as well as bringing in new partners on a regular basis. So she's the politically correct one and does the networking, and I'm completely politically incorrect. So I'll let you deal with.
Okay, we have two MDR-TB applications that have been rolled out nationally at the moment. The biggest one being the MyLink. It is with the Global Fund and the Johns Hopkins University and IMOCA. At the moment, we're running it in one district, it's called the Uga district of KwaZulu-Natal, at 3 facilities, but we're currently running out at 20 high burden districts of MDR-TB at the moment. And it's got 3 apps. It's got your primary healthcare app, where you actually screen your patient with a sputum and put them into the system with a unique barcode and capture all their demographics. The one advantage about these programs is you can control the IDs. You can get the ID numbers from the patients because you can control it. It's still a study. And then once the GeneXpert result has flagged positive, a linkage officer will receive, okay, it's not on these slides here. A linkage officer will have an app as well, called the Linkage Officer app, and she will receive an app on her tablet to say there's a new patient on the horizon. It's got all the patient's details. She can go and phone the patient, trace the patient, and bring the patient back into care. And then we have an MDR-TB app. It's a blue one, so when the patient reaches the clinic can register the patient and say, acknowledge, okay, this patient's on treatment. And to date, we've had almost all of our patients linked within less than 5 days. In fact, some of them within 24 hours even by the system. And those are just enrolled patients across the 3 facilities. I'm not going to go into much detail. Like I said, we're expanding into the 20 high burden districts. This is the M4JAM solution Wendy was talking about. So it can be involved in many areas in the public sector, but the most powerful one, I think, is actually incentivizing behavioral changes amongst healthcare workers and in patients, taking charge of their own health and empowering them to go and find the clinics and get treatment. The mHealth Hub So the primary aim of the mHealth Hub is to provide a centralized near real-time monitoring dashboard together with a standardized reporting framework of mHealth data that can facilitate and coordinate various requests that are being made to our group and the NGOH. The ultimate goal is to link as many patients to care as possible and to provide monitoring and reporting to various levels of the healthcare system. This mHealth Hub idea was actually stemmed from an idea I had for my PhD thesis. I thought it was quite insignificant a year ago, but it's actually been adopted quite well, and I'm quite happy about that. And what we found is that the NHLS and the NGOH have been approached by many app developers out there. And all the data is siloed, and there's a repetition of work, and there's no data sharing through all these apps. So we have all this loose but very valuable data out in the field being collected through mobile technology, and it's not being centralized and fed back, and nobody can leverage from each other's data. And we found that in NHLS we can provide a very valuable service by filling in the gaps automatically into all these apps that are out there with lab results that we can all share, and demographic results too. So this is the architecture. I don't think I'm going to go into it too much, but really it's going to be HIPAA and POCT compliant. And this middle part here is actually the hub. So we can do near real-time monitoring, mHealth operational reporting as well. We can do clinical management and patient management as well. And it's going to be, it can be fully interfaced with the NUH's health information exchange that they're busy developing, as well as EDR, tier.net, any other electronic health records as well. I'm not going to do too much more on the InfoJam. Wendy, we've got 3 minutes left. Do you want to talk about this quickly?
Well, I think it's quite a neat way of approaching community healthcare issues, and whether it be getting people to come back from their MDR drugs, whether it be sitting in the clinic and monitoring the performance for some of the things. What they do is they take a huge problem and they turn it into single jobs. This gets registered on a system and gets put out. You can register as a jobber. So you can be a community member, register like you can as an Uber driver. You grab a job. If you are GIS checked, if you are known in the system and you submit the job accurately with approval, then you can be paid. And we found many people it only takes 20 or 25 rand, and they're prepared to do things like mobilize. And we've even got it in other sectors where it's being used as on a franchise basis. So if you wanted to expand that HIV rapid testing, you might have a franchise owner who has a whole series of jobbers that she's responsible for, and they get verified by someone else. They're also linked to a mobile money banking system, which is POPI and all the compliance that's required. And they can then, if everything the patient has answered, and you don't make them enormous jobs, up to 9 or 10 activities. And when you have done that successfully, you send it back. M4Jam will say, right, he's fine, we'll transfer into that cell phone. That can be cashed out at the moment at Pick and Pay.
PEP is another one.
Pick and Pay, the bank. You can get this as a cell phone voucher. We've even got platinum, it's like air miles. We've got platinum, gold, and whatever members. And so you can get fast targeted insights or activities by bringing the community, creating employment as well, and using HR resources that we don't have in the health department on a more expanded basis. And I know you're all going to be very jaundiced, as all funders are, but I mean, if you compare, I wouldn't get in an Uber till I was late for a meeting, and now I'll travel anywhere with them. So it's a way, I think Discovery even delivered vaccines, the flu vaccine via Uber. It's a way to get jobs done in the community that could otherwise be
That's it. I think we've finished now.
Yeah.
Yep.
And Lindsay gave a whole load of examples. We just can't find a funder to fund it because they think it's too risky. And if you think about it, what we spend on getting an MDR person onto treatment and keeping treatment, if you were to pay someone 20 grand to get them to the right place, it really becomes nothing in the scale of costs. So while it has a lot of problems, a lot of ethics to work through, I think it's another innovative way of harnessing community energy.
Okay, thank you very much. So we're probably in the last 90 now, in the last 90 minutes. Because we've been sort of wrapping up as we're going ahead, and we've got a scheduled rapporteur session at the end, which I'm going to dispense with. Because we are going to quite rapidly give you feedback in a written format. So the last 90 is open for discussion. There was a lovely plug here for Money for Jam. I think it's a value. You don't. You really don't understand the rules of operating in South Africa. I do think there's a whole bunch of places where it could be valuable. You know, I can see how we could use it, for example, quality assurance in a clinic, etc. That could be interesting. So I think all of the partners will pick up on that. These guys are on the website, so it's not difficult to find. So this is open for discussion, and perhaps the first thing to open up for discussion is you should show us these wonderful pictures, but I told you over lunch, I've been seriously considering hiring somebody to hack your computer. Because unless there's a way we can get this data available to the partners, it really doesn't serve much purpose for what we do. So that's the first, I think, very open question to you. What would it take from our side? I just want to check with you. You all agree you could use that strategic data, right? And we don't need to drill down to individual patient stuff unless it's in the context of tracking people. But it would help us enormously to understand which clinics have got good results, poor results, etc. So you said you need funds, but you've been very Protestant here. I need some money, but I'm not going to tell you how much I want. How much money do you need to make it available to us?
Okay, I'm not selling the Department of Health data. What I'm in the business of is...
Oh, it's true. Now we're getting the health advisories
You
here.
don't only use data for surveillance. I'm so tired of us just collecting numbers everywhere, and it doesn't translate into patient care.
That's why we're asking for a question.
Yes, but you have to listen. Because you never put unique identifiers in that, it has required 2 years of work. In fact, maybe even more.
I'm going to speak. It doesn't cost anything, does it? It needs an MOU between yourselves and the NHLS. The NHLS is a public sector funded, publicly owned organization that's there for the public benefit. They have data which needs to be protected in terms of the law, but there are already groups that have access to it, and you need to get relative access to it. It's not for sale. We need to set up an MOU between yourselves and the NHLS.
Okay, so it's free, and you don't want any money as technical assistance to help you get this thing.
I mean, I'm not the chair, I'm not on the board, but this data is free and is freely available and has been. What we wanted to do was make sure our dashboard gave accurate data. We're hoping Jürgen will approve security levels, and then the data can be released nationally overnight. I mean, it's all ready to go and all ordered and organized. So we can't sell, we're not in the business of selling data, but what I can tell you, Tim, is that we actually can't afford at the moment to manage our central data warehouse with the level of skills that are required. So if anyone wants to assist, it's really funding exceptional skill to keep a data warehouse of this nature going. Sometimes it requires and has required international recruits because it is so sophisticated. I mean, each parameter is matched to the laboratory, matched from the location to the laboratory, to the information system, to the central data warehouse. So what it really requires is a sustainable skill set. We have put this as a high priority for the board of the NHLS, but that is what we need. That's what we need, skill. Tim?
Okay, so Tim, this MOU, where do we get it?
So, I'll get to that. There's principle and there's detail. The principle is that the data is there to enhance the health of the public sector, and therefore those that are involved as development partners must get it. There's detail about making it accessible in the right format and to have the right people on board. Then when it comes to the money to do it, it has to be a sustainable solution. I'm not sure that a once-off fee or a fee from those that are getting donor money is the way to staff your public sector setup. So we need to find a mechanism to create a sustainable, highly capacitated unit so that when you want data on District X, you can get it. The MOU, there's a boilerplate MOU already in place. Right to Care signed it, Aurum signed it, a few of us have signed it. So it's already in place. It may need some updating, I don't think so, but it's there. Ask Joyce Mogale for it, or ask Wendy for it. It's there.
We're making a note. We know where you will all find it. We'll ask it. And I'm sure Wendy will help us and Tim will help us and we'll distribute it to all of you. Because you all need this data, full stop. Okay.
I'm afraid he's going to go back and say I'm selling data or not.
No, I said you're not selling data. It's not for sale.
Yeah, but we...
Not for sale.
Right, so that solved the first big thing. You are wonderfully vague, but I do understand Tim's point. It's difficult to build a sustainable solution with donor money that's going to disappear. But again, it's up to us as the partners. We can discuss how there is still technical assistance at national level. There might be possibilities around. Right, who wants to open up the discussion around this issue? We're on the last 90. Are we in agreement that our practical solution is we need to be able to see the data and that will solve the last 90? Right, there were other suggestions that were made about patients getting access to data. Suzanne wants to chip in, then we'll go.
To ask, I understand about not relying on donor resources for human capacity, but is there an opportunity to build touch-of-the-button type of reports into the system so that it would ease future human effort to generate these types of reports? And I'd like to propose that maybe if there's an opportunity to get people together to say these are the types of reports that could and should be standardized.
So a forum has been set up at the NHLS to work on the type of reports that people are looking for. Having said that, that requires technical skill. So we have it, but we maybe don't have it in as to be able to deliver to everybody immediately all the time.
But can we suggest, Wendy, that again you tell us how to get hold of that forum? So if we as a partner want to engage, we can at least understand what is possible, the art of the possible, and I think that's where the short sort of type of technical assistance, can we fund a consultant who helps you to build a report that meets the needs of the PEPFAR partners? It's completely doable. And it doesn't create a long-term sustainability problem for your board.
Yeah, and we can present that also, live, so that you could see that you can make changes that give you different reports.
It's either that or it's the ninjas who's going to come and hack your laptop. All right, who wants to tip?
Different point. You said that your comment there was, now we've sorted out the last 90 when we have that. I think we need to differentiate between tools and processes, and I think that what Wendy and her team are going to provide is a very sophisticated tool, not a process to rectify. So that tool needs to be informed by the questions that you want asked of the database. Do you want provincial level? Do you want district level? Do you want sub-district? Do you want cluster? Do you want individual facility? You need to populate the questions that are asked of that database, and that's the tool to then inform your team's processes about going out and improving. Are you going to, based on the results, you then roll out a program. So let's just make sure we're differentiating that Wendy's team are providing this incredibly sophisticated tool. The CWD Corporate Data Warehouse is the most sophisticated tool in the country to monitor the success of our priority programs. But that is exactly it. It's a tool, not a process.
I think point taken. I think the vast majority of us at this stage probably are very interested in drilling down to facility. There's an interesting, observation that came from Broadreach, where they found if you focus on the 10 worst performing clinics in a district, you have and you improve the services there. You've got a dramatic improvement of that district's performance on a national basis. And I think that will influence all of us. Right. The subject is still open for discussion. Professor Fenton, look at the camera.
So I think it comes down to the heart of it, is we're doing this infinite amount of training, this infinite amount of technical assistance. As you said, Broadreach has solved the problem. There are 10 facilities, not 100 that need help. And the point is we don't know which those damn 10 are. And if we could really focus our resources on where, like, the viral loads are great. Did you do sufficient viral loads relative to the number of people in treatment? And were they undetectable? If you were doing sufficient and they were undetectable, the staff there are doing their job, the adherence counseling is fine, you can leave them alone to get on with their work. You can focus on those 10. And for us, it would be really useful to have that data, as you say, as a process indicator where we can then focus the interventions in a more intelligent way. And I think that you said it's going to solve the first 90, you're right, it's not going to solve it, but it's going to help us to work out where the problems are. The same goes for the second 90. Is starting to chart where those programs, how many of those patients actually are making their way into care, and how quickly are they entering care. Because that's going to allow us again to see where is the problem. Is it the way I think, which is that there actually isn't much of a problem, or am I wrong and the patients are falling over hand over fist and dying in the rural areas?
Thank you, Francois. Right, who else wants to wade in on this issue? There was quite an interesting suggestion from Wendy that data theoretically could be made available to patients. So a patient could have a record of they could start tracking their own viral load, for example. And I know that if you look at all the app development stuff, that is the big thing that's happening internationally, is people are asked to manage their own health. And I think when this is a throwaway remark over lunch, he said, but a lot of our discussion is sort of very paternalistic. It's about what we're going to do for them, the patients. So there's probably worthwhile to have a bit of a conversation around, is this a way of empowering patients to actually, when I use the word empowering,
A lot of reasons, for ethical reasons and because we don't know what it's going to do. We are not doing this on a large scale. We are, however, working with the World Bank on a project giving patients, after consent, understanding viral load and CD4 results. That's obviously still a research project. And we don't know whether it's going to make a difference, but I suspect it will. I mean, just ordinary SMSs have been shown in many studies to get people back to the clinic by just saying, please come back to the clinic. But if they understand how what a viral load greater than 1,000 means, I suspect we could change people, I don't know, to look after their own health. I could be wrong, and the study will tell us whether, we're right or wrong. But the World Bank are doing it in more than one setting.
Thank you very much.